I'll talk to you like a little bit about reports. Reports are super important. Okay, we're radiologists. The patient like doesn't even know you exist most of the time. A lot of times they think you went to tech school and you were like in tech school like for 2 years, and that you're the guy who presses the button like on the machine to like turn it on. The guy, you're the booming voice that says, "Please hold your breath." But your patient's going to get that report. They're going to log into my chart. They're going to see it. Their doctor's going to print it out for them. If it's misleading, if it's confusing, if it has gibberish in it, that reflects poorly on you. The referring clinicians, the same thing. I mean, you talk to them more than the patients. I mean, they call, they ask questions, but that's how they get to know you. And if you're putting in idiotic reports all the time, reports with spelling errors, reports with grammatical errors, that reflects poorly on you. It reflects poorly on the department. It reflects poorly on your whole institution. Because if they can't trust your reports, you know, what are they going to do? That's how they interact with you. Finally, you guys are residents, okay? Like your faculty judge you every single day, okay? Most of you guys do great 99% of the time. Even like when reports are bad, a lot of times it's like that you were rushed and, you know, we clean them up a little bit and everything is fine. You guys do great work. But these faculty, this is how they get to know you. And like you may want to do a fellowship here. You may want to do a fellowship elsewhere. And they have to sit down and think like, you know, what was this resident like? And like the thing that we see the most, I mean, we interact with you guys in the reading room, but when we see sloppy reports like again and again, that's like how you get to know people, and it reflects poorly on you. And like I said, like you guys, like most of the reports, like John's been working with me this week, and like most of the reports, like some of them see findings like I don't even see, and I'm like, that's like a great call. And like many times we just make small revisions, but just be aware that your reports are important. One of my faculty, like in my residency, he had this little handout about like what a report was and like how we should craft them. And it had this quote that like kind of stuck in my head. And he said the purpose of the radiology report is to create the correct state of mind in the reader. And I truly believe in that, because your goal is for the clinician to get the right idea like about what's going on. Like, is there something really bad? Is there something not so bad? Is it bad but not urgent? Or is it normal? And in order to do that, you need to be organized. You should put the important findings first, and you shouldn't like bury the lead. Don't like say like, oh, the calvarium is normal. Oh, the orbits and paranasal sinuses are normal. Oh, there's like cerebral edema with a centimeter of midline shift and uncal herniation. Like that's not what you want to do. You want to get to the lead first, create the appropriate impression. And then honestly, like that other stuff, if it's not even in there, it actually doesn't matter, because you've created the appropriate impression that like there's something urgent that has to be dealt with. And if there's confusion about those other things, then they can call you or whatever. Then you can talk about the mucus retention cyst. Then you can talk about the cerumen and the external auditory canal. But those are not, once you've created the appropriate impression, like you've done like the majority of the work of the report. PowerScribe is your friend. There are templates. In neuroradiology, like we've worked on templates a lot. I know there's like a generic resident template like for on-call reports. I think in many ways, the modality specific reports, like at least in neuro, I don't know what they're like in the other sections. I think they're useful for you guys to just use the modality specific ones. For many of the reports, they come up already. So it's like a CT brain, it just pops up. I mean, you can delete it if you want and use the like generic one, but a lot of that like has valuable sort of useful information that can kind of guide your search through. It may remind you, yeah, I should look at the soft tissues. Yeah, you know, I should look at the sinuses, like that kind of stuff. When you're using templates, like make sure you delete the negatives. Like this constantly happened. Like when I was a resident, we would like have ultrasounds of the right upper quadrant. It would be cholecystitis. And then like we'd leave in the statement that says like the common bile duct is normal and the gallbladder is normal or whatever. You make sure you delete those. Again, that like kind of gets back to like it looking bad on you and just causing confusion like among the clinicians. You got to train PowerScribe. You got to do that 10-minute training or whatever, but you got to train it more. This is like my dog when I was a kid. This is like a collie puppy that we had. You got to treat that thing like it was a dog. You got to speak slowly and clearly. Every time it messes up, you have to correct it. And we were talking a little bit about this in the reading room before this. If it constantly messes up a word, you have to train it. You have to like train a phrase. You can train it to say phrases. I told John, like, one of my pet peeves of all time is how foramen of Monroe is spelled. Monroe doesn't have an E at the end, like the president. It just has an O, so MRNRO. PowerScribe will never get that, ever. But you can train it to say the phrase foramen of Monroe, and it will get it right every time. So you can train phrases up to a couple of words long. Some words it will like never get. That's just one of those things. If there are things that you find yourself saying all the time, make templates for them. Like, just go ahead and make a template. If you've said something more than once, like in a call shift, you need to be thinking about like how you can minimize the time you spend on that, and also the typos, because every time that you say there is periventricular hypodensity, which is likely age-related microvascular disease, it's going to screw that up. It's going to change microvascular to whatever, something else. So make templates and like get rid of that stuff. These are just ones that I use all the time. Use the ones that work for you, okay? Make them and make it work. The things that you're saying all the time, I swear, I say this like 10 times a day. If you're like on call on a weekend, you're gonna say this 10 times. Just change it. Just make it PowerScribe atrophy. Just put it in every time. And then once you learn what phrasing like the faculty like, then you're not saying it a different way every time. You're just saying it the way they like it. There's gonna be no typos in there. Every PowerScribe phrase like does not have typos. This applies to other areas as well. You can kind of make fun of like other other specialties. Like you can like have ones like PowerScribe ground glass like for chest, and it can just be like, this is likely a non-specific inflammatory or infectious condition. Whatever, but just like do something to like make your life easier, make your life faster, and make your reports look better. PowerScribe is also your enemy. We've talked about this. It will pee on your carpet. It does not like the word no. It's so short. There's like a huge difference between no evidence of subarachnoid hemorrhage and evidence of subarachnoid hemorrhage. We see that a fair amount. When you like describe all the findings that are normal, and then your impression is evidence of acute cholecystitis, that's bad, because the ER is like, what? I don't get it. And since they don't read the findings, then they're like calling surgery, and that just makes everybody look bad. Just be careful about that. Sometimes it just makes up stuff. The history always gets messed up. That paste-in history includes the word woman or man. The faculty here don't like the word woman or man. I mean, they don't like male or female. They prefer woman or man. Then I was talking with Dr. Barkovich, and like we were discussing like whether or not we should just not include the age and gender at all, because it's in Apex. It's right above the report. Does it even add like any value? Because he says like he gets an email about once a week asking him to change the gender in someone's report because it got put as woman and it's really man, or vice versa. The patients don't like it because they read the report. It also gives the impression that you were actually reading a study on the wrong patient. If it's a 60-year-old man and it comes out as 6-year-old woman, that's totally confusing. So if you're including that, just be careful about it. He also had an interesting story about how a patient like sent him an email. It was a person who had a female to male sex change, and there was a mention in the report of, I don't know, something in the uterus, and he wanted the mention of the uterus taken out because he was living as a man. These like gender terminology like it's loaded terminology, and like it's just probably like we can just do without it. Some of my personal favorites. These are just ridiculous. For some reason, 2 views of the right knee came out as 20 scoops or plenty. And the MSK attending that I was working with, he was like, well, I mean, PowerScribe's right, like 20 scoops are plenty. I don't even know why the word scoops is like in the dictionary. No narrowing of the joint space came out as hello infiltrate. I mean, that's like ridiculous. This is like a good one. And it's especially funny because a clinician called and said, I'm worried about this patient. Like, what is pseudomembranous osteomyelitis? It's not a thing. Flank pain, cemented flank pain. Like, I don't know like how that came out. For me, extremity always comes out as Germany. I've never been able to fix that. But like, just be aware of that. Like, PowerScribe also hates the word mucus. I don't know, and like diffusion. Diffusion is a big one, like reduced diffusion always comes out as reduced effusion, like plural effusion.
Transfrontal will be transvaginal.
That's not good. Like there are like stories around like about the word raped or sexual like ending up in reports. Like that's not good. Transvaginal. I mean, Powers Card should have a flag where that doesn't happen. Anyway, pay attention to your reports. Like create the appropriate impression. Don't imagine yourself like on the stand having to explain that there was a finding that was missed, and it would have been missed by any normal, careful radiologist, and then having to read back to them a report that has typographical errors or gender errors or age errors. You're like losing a lot of credibility there. It's going to be very hard for you to say like, well, this mass would have been missed by most radiologists when you had a sloppy report. I mean, just consider that. Now we'll move on to like a little bit more neuroradiology specific stuff.